Foremost, thank you to you and Elena for the vision to start this initiative, and I'm sure it is going to grow significantly over time with input from all the amazing folks that are doing meaningful work across the state of Texas. We have a fantastic presentation and conversation for you today. And we're going to try to make it as interactive as possible and hopefully as fun as possible. I think you all passed the first geekiness test by signing up and joining us today. Measurement is not probably one of the most exciting topics. I think to us it is, but maybe not to everybody. But I think it's also one of the most important things that we can do across the spectrum of initiatives, particularly as it comes to non-medical drivers of need. So we're going to try to use this as an introductory session and then build on it over time with subsequent sessions. Again, not only from the experiences that we have, but with experiences and knowledge from all of you. So we're going to use this topic of applying systems thinking to NMDOH impact measures. And why don't we get started? Since this is our first time together, I would like to take the opportunity to also introduce not only some of the speakers for today, but some of the key folks that are part of the steering committee. As Jackie introduced myself, Steve Meff, I'm the CEO of PCCI, and we spend our time at this intersection between data science and digital technology and social determinants of health. I have the honor to co-chair this with my colleague Leslie Wainwright, who is the Chief Strategy and Innovation Officer at PCCI. And I'll offer for as I introduce everybody, a couple of fun facts about their career. Maybe a lesser known fact for Leslie, who those of you that met her before, is that her PhD is in pathogenic microbiology and her postdoc in vaccine development. So as you probably imagine, her expertise came in pretty handy during the COVID last few years. She also is a highly rated, consistently 5.0 out of 5 executive facilitator for the American College of Healthcare Executives. And right before she joined PCCI, she was an innovation executive leader at RTI International. They know something about measurements. One of our colleagues as part of the committee is Semanti Basu. Semanti is the Director of Measurement and Evaluation at the Michael and Susan Delk Foundation. And what I find fascinating about Semanti is that her specialties include not only social impact measurement, program evaluation, system change and assessment design, but some really unique deep expertise in the RASH methodology and application and psychometric theory and applications. So I am sure Semanti, as she already has, will contribute significantly to our knowledge in this effort. I know that many of you know Linda Highfield. Linda is the Associate Professor and Distinguished Chair in Population Health Management, Policy and Community Health at UT Health Houston School of Public Health. And there were so many things that I could pull from for Linda based on her relevant and so diverse work experience. But a couple of things that really stood out to me was her leadership on AHRQ R18 dissemination and implementation science study, because it was focusing on mammography screening appointments and the adherence outcomes, particularly as we look across healthcare practices. So I thought that was just a really meaningful component. And the other key component was her work on geospatial software application for health systems. So Linda is joining us today for the presentation, and she will provide insights and color commentary throughout. Finally, last but not least, Mark Rosen, who is the System Director of Community Impact for Common Spirit Health. And for those of you that you might not know, Common Spirit Health was created back in 2019 when Catholic Health Initiative, CHI, and Dignity Health came together. And what I find fascinating about Mark's background and expertise is that sort of he's seen this from every single angle. Early in his career, he was an executive at YMCA National. After that, he actually was a director of research and evaluation for Unite Us, one of the technology vendors in this space, alongside with Find Help and Pieces Connect and others. And now he's applying his knowledge from a health system perspective. So you will hear from Mark today as well. So I took a little bit of extra time to introduce the steering committee members and some of the folks that you're going to continue to hear from, not only today, but as we move forward. Some grounding principles. First and foremost, I hope that you did not come to this expecting us to have all the answers, because we certainly do not. Hence, we are looking for active participation from all of you. We're looking to learn from you. We're looking for you to actually share with us in this knowledge as we build it together. Number two, we strongly believe, I hope you share in this belief, that measurement is not the last thing that you do, but the first, because it's so important to really understand where we're going, how we're going to know that we get there before we actually implement and use particularly these multidimensional areas of addressing non-medical drivers of health. While impact measurements can be overwhelming, can be complex, we certainly believe that's achievable, and there's a right place, a right way to start and build on that knowledge over time. And certainly measurement is for everybody. We know it takes time. We know it takes managing expectations. And I think most importantly, also takes the right frame of mind. And I would say not only as we approach today's conversation, but subsequent ones, we should approach this with the mindset of we can do it if, versus we cannot do it because I think we can find answers as we continue to ideate and create this together. To make this interactive, we have your first question. Probably the most controversial question that we'll ask you today, which is your favorite city in Texas? So if you pull your cell phones, and if you don't mind going to menti.com, you will be prompted to enter the code at the top, and then you can choose within this selection of 5, what is your favorite city in Texas? So let's all practice.
I think this might be skewed by the residences of our attendees.
Which is great. It gives us a sense of the geographical distribution of those that are dialing in. So an indirect measurement to start with.
Good. All right.
I know I was expecting this, and I got the first reprimand that I have not included all the major cities in Texas. That is correct, and I apologize for that.
Sure.
You're right. There are not all the ones. So you pick your favorite non-city where you reside, or maybe your second favorite.
Very. All right. The system works.
All right. So the system works. Certainly, Houston has come up on top. Here's sort of the I think what now we're getting into something that's much more relevant to today's discussion. But keep that up. And one of the things that we wanted to generate to start with is a word cloud. So type in what is the first word that comes to mind regarding the measurement.
HEDIS. I like prioritization. It's good. ROI, good. think 35 is a good representative sample.
Fantastic. You know, I'm surprised nobody had, or maybe I don't see it, overwhelming as probably one of the key descriptions. But no, thank you for doing this. We're going to incorporate this throughout today's presentation, and I hope the answers that we'll gather will be additive and you'll find them useful as we share this with all of you, and you might be sharing this with colleagues.
Wait, Taylor Swift.
I love that. If anybody has tickets, you know, it's a great way to trade for certain things.
That's awesome. All right, onward.
I think, Leslie, that was just to make sure that we're actually paying attention.
Right.
All right. Well, here's sort of the plan for today. I am going to take just a couple more minutes to guide you through the impact of measurement and just some grounding slides. I'm going to then subsequently pass it over to Leslie to talk about impact measurement, what the requirements from a data strategy perspective. Mark will talk about current challenges and pay particular attention to that because, you know, not that my sections or Leslie's are not impactful or meaningful, but I think you're going to have fun with the section that Mark's going to share. Leslie's going to come back and talk about approaching measurement through a systems lens. Linda, as we mentioned, she's going to chime in throughout. And then we're going to pass it back over to Jackie for the breakout sessions and have some more engaging conversations. So that's the plan for today. So let me guide you through a couple additional slides just to orient everybody, set a level of starting point for as we embark on this discussion, not only for today, but again, subsequent sessions as well. This might be complicated, but you know what? Measurement can be complicated. So I think we need to recognize and set the framework that measurement initiatives operate on a multiple spectrum of both complexity and time. So what this diagram shows is this two-dimension of time frame at the bottom and scope or complexity on the vertical axis, the y-axis. And also, I think it's really important to recognize the different types of measurement because they're all important. And there's a sequence to be able to build this. At the very bottom or the beginning of this, process or output measures. That's oftentimes where we need to start. That's oftentimes where we start to get an understanding of the effectiveness of the program operations as planned. It could be things as simple as how many individuals are we able to screen? How many individuals are those that we screen? Are we actually referring and helping access services to address their non-medical drivers of health? How many, as it gets into more of the outcomes, how many of those individuals actually are able to solve those needs if you follow up and what time frame? That starts to get into the program achieving its operational or objectives. And finally, as you move all the way to the top, is really starting to measure and understand impact. Really, what is the output or what is the outcome of that? Again, one important thing is that these are additive. There's a place to start and to build upon each other. And from a content perspective, from a knowledge perspective, that's what we're hoping to do today as well. And by providing not only examples, and then over time, we'll build on this knowledge also. Let me pause for a second. Linda, Leslie, anything else to add on this? Because I think this is an important grounding type of a slide.
The only thing I would add is when measurement can get complicated is when you have misaligned communication for what stage you are in this, and you're really at the point where you're at that lower left and trying to get your footing around our process-oriented measures, and you might have stakeholders or other individuals who are expecting you to have those larger impact indicators in place. And so having a clear lexicon and shared vocabulary and a shared understanding on that stepwise approach assures that everyone has that common expectation for what you're able to show when.
Yeah,
Fantastic.
Leslie, just from an experiential, standpoint, when I think about not doing work in non-drivers, social drivers of health, it takes time to build up the data to get to those impact measurements, right? And so I totally agree with you, because it's helpful to communicate to stakeholders, hey, we're going to need to sort of collect data in order to even be able to do those impact measurements down the road.
Absolutely, great points, Mark. One of the other on next slide, the Mentee question number 2. Where in the complexity spectrum do your measurement initiatives reside today? So it'd be good to get sort of from the one end of measuring process outputs all the way to measuring impacts. Where do you feel, based on your work, your organization, you are today?
That's great.
All right, fantastic. No, thank you. A lot of folks participating, and it's really good to see. And I would say it's probably something that I would expect. Actually, I would say that this group is probably more sophisticated than most, because everybody seems to have a level of experience, and actually pretty significantly a large number measuring outcomes. Which I think it's an important and relevant component.
And then when we break into the breakout groups, I think this bell curve around kind of where we are from a leveling standpoint to inform some of that discussion in those smaller groups will be important. So for facilitators on this call, let's recall this distribution as we go into those sessions.
Absolutely.
And I just wanted to add the comment from the chat that we're looking at them in the Mentee poll as independent, right? But these are interactive, they're connected. And so we had some comments in the chat that people are finding themselves kind of in between outcomes and impacts, right? Thinking about how to move on that pathway.
Got it. Thank you, Linda.
Linda, fantastic, great add. Just a couple more grounding components, and I think most folks know this, but I think it's important to recognize that effective measurement, and Mark alluded to this as well, it's multidimensional. Certainly there's the time to impact, whether short, mid, long term. What to measure, we just talked a little bit about, we're going to get a lot more into it. Who's being impacted, and that's multiple levers, whether it's the individuals, our neighbors in the community that we're trying to impact first, but also what is that organizational level, what's that community level, what's that population level, and then as has been alluded to, it's what is the required data. That's this component that gets fairly complex, it takes time, and the definition around the data sources becomes something that's so important to be able to do that. I think one of the other part of this multidimensional thing beyond the 4 on the next slide is to recognize that effective measurement also requires an understanding of the connections across multiple initiatives. And this is, I think, a simple but a good example where if you're really trying one of the things to impact earning individuals in the community, earning a living wage, there are upstream key components that need to happen that contribute to this longer term goal. Anywhere from something like Initiative 1 is to increase the high school graduation rate, or for those that are able to leverage that education to have a job, initiative number 2 around being able to have affordable childcare. Because if they're not able to have that option, they might not be able to participate in the workforce or the type of jobs that gives them the opportunity to earn the living wage. And then a potential initiative number 3 is, how do you create the tuition subsidy programs to enhance and continue to elevate the skills of the workforce towards higher and higher paying jobs, whether it's technical schools, community college, any type of education or high levels of education to do this. So I think a good example how we think about the connections and the need to identify partnerships who can impact and influence these correlated and upstream measures. So if we move on, one of the other key points I want to make is that getting started with measurements requires defining the problem up front, creating a very specific goal, and awareness of what information is needed to monitor that. And I'm not going to go into detail on this slide, but what I'll use here is one of my favorite quotes of all time. It's from City Slickers, and that is, "We're lost, but making great time." So if we don't do these things right, how are we going to know that we're making the progress that we need to make? How are we going to know the corrective actions that we need to take along the way to get there? A good example of this on the next slide is if we apply it to diabetes and the correlation between nutritional and food insecurity relates to diabetes. And if you look at it from left to right, from the current health outcome to the disease-specific indicators, how the social or the non-medical need indicators correlate to those, and ultimately what we're trying to measure from a process and output perspective, we focus this example more specifically to those output and process measures. You can actually see, and a number of you have done this, where you can start to build those other higher level ones. But what is understanding the eligibility criteria of the population, understanding that by demographics, disease state, different areas, the current levels of preventable ED visits or utilization by the diabetic population rates, etc. So we wanted to provide this example. It's too detailed and dense to go through it today, but wanted to provide it to you as a follow-up, as something that you can go back to make it a little bit more concrete as we go through these concepts. And finally, the last piece that I want to share with you before I pass it over to Leslie, that is this concept on the next slide, that effective measurement can certainly drive change. But data, while data and numbers are important, I think there are 2 other key things that we need to make sure. One, it does not eliminate the need for us to talk to people. We can only use data to take us so far, but at some point, we need to talk to people. And the other component is we have to make data information reliable and relatable. We need to be able to tell a compelling story, and the data is helping us tell the story. So measurement need to adjust to what people and stakeholders care about. There shouldn't be just one measurement, but also a nested set of measures that each of them speak to what each group cares about. So with that background, Leslie, let's pass it over to you as we get into the next section.
Perfect. And as I'm doing that, Linda, is there anything in the chat that is worth commenting on before we make the transition? I'm going to go with no. Okay, very good. So
sorry, it would take me just a second to get there. I was looking at the chat and unmuting at the same time. There's just one comment in the chat about the importance of integrating social care interventions with payment and thinking about how payment models fit into our evaluation approach and how we can inform those. And I think that's a great point.
Oh, it is a great point. And that specifically goes back to the telling the stories that people care about. And if it's a funder or a payer, particularly if you're developing alternative payment models, the nouns and verbs around that impact story are going to be very different if you're talking to a clinical team. And so it's this understanding of what stakeholders are most vested in this non-medical drivers of health narrative. So it's not one story, it's multiple stories, to Steve's point, and getting that wrong or not having a grounded understanding around what that stakeholder audience really cares about is one of those places where that biggest miss can occur. And I know, Linda, our collective experience with AHC as one of those alternative models, I think we're still finding the way forward in terms of how those type of integrated models kind of really hit the mark with different Medicaid plans, et cetera. And so I'm curious about how you've tailored some of your narratives around AHC specifically to different funders and payers.
Yeah, that's a really great question and comment, Leslie. So we're really deep in the weeds on this right now, right? We have a working group together that are in the process of developing an alternative payment model to sustain AHC, and we're working to co-create as a team what that can look like, and then how we will approach the MCOs and the potential funders to talk about the impact of AHC. And I think, some of the things that we're hearing so far from the group that are really jumping out at me from a measurement perspective are that a lot of the people coming to the table are coming to the table from the perspective of the financial side. So how do I get paid to do this work? And don't get me wrong, that's really, really important. But I keep trying to re-anchor the group to be patient-centered and to focus on the outcome that we're trying to change. And that's a system thinking approach to this problem, trying to bring everybody to that common thread that we all see as the important driver. And then we'll figure out where in the system the intervention should be placed, who should be doing it, and how to get paid for it. And so I think for me, bringing that systems perspective and re-anchoring everybody back towards it is something that's really jumping out as important as we develop this work.
That's really good. And that dovetails really nicely into, as we're talking about the data strategy piece. So a couple of themes, we have those initial principles that got us started. And again, those came when our steering committee met for the first couple meetings to talk about our mandate within the overall consortium, but also as we were thinking about this topic. As I think about the specific piece around creating a data strategy, again, it might fit within both, but for me, it's this, begin with the end in mind and have the aspiration and then work your way back to what you can actually collect today. I'm going to show you a couple examples of data strategy around this idea of crawl, walk, run. The idea that we mentioned in one of those principles where this can become overwhelming. Now, we don't want to get in this situation where we just get in paralysis because we have what we ultimately want to do. We can't exactly see our way forward to that. So we just kind of get caught in motion or just stuck because we can't figure out what to do. So you will see whether it's the broader measurement strategy or where to begin with what data to start collecting. There is a way to begin. And the other one that I love, because I think about it every time I work out, and it's progress, not perfection, right? So we're going to be able to do, again, a little bit of this as long as we're making directional progress. That's an important thing. So we at PCCI have had a chance to do a lot of work with both impact measurement. Again, as a steering committee, we've had a chance to talk. As Steve introduced PCCI as an organization, hopefully you took away we love data. And one of the things that's become really clear to us is as we talk about the power dynamics within a community, when we're trying to think about these cross-sector or multi-site type of collaborations, there's really this unusual power dynamic around whoever seems to own the data kind of has the power. And that's both something that's real and we need to figure out how to manage as we think about collaborations, but it's also a strategic recognition that depending on how non-medical drivers of health ultimately mature into how we address them in both community and clinical-based settings, the ability for organizations to have their own data infrastructure and the ability to have that right-sized way with which their own metrics are collected almost is, hand in hand with kind of charting your own destiny for how you have that seat at the table for what it looks like when we're talking about, effective and actionable uses of data. So data here is something that's partly going to be a strategic lever, and it's also one of the greatest places for collaboration. Right now, we know that some of those barriers it's just people don't want to share their data, right? It can still be really, really tricky. So we're going to, again, touch on both of those things. But as we get into this idea around what to select or how you begin with getting the right measures around an impact measurement strategy, here's a list of categories of down selection that we use routinely. And often what we'll do when we work with folks or we do ourselves is, again, thinking with that end in mind, like what are all those things you might like to collect? And then you go back and do that down select against these series of criteria: accessibility, causality, feasibility, relevance, and credibility. And that'll mean you probably start with a list of maybe 20 or 30 things, and you might end up with a list of 5 or 6. Right? And that means or you'll recognize that, well, maybe we really want this one because we can get it. And it might not be the best on the credibility front, but you've gone through and made some very thoughtful choices around the type of indicators that you can get and their validity and relevance for what they're going to tell you. And this goes back a little bit to that storytelling that Steve, Linda, and myself we're touching on, because part of that storytelling is to affect change and to have individuals take risks, knowing that we in healthcare are just wickedly risk averse. So when you're telling that narrative and you have data that you can say, well, we picked this because, or this is a gold standard here, or the ability to justify the measures you selected and why, it goes a long way to moving hearts and minds as you're telling those particular data-driven stories. The other thing is, we know the holy grail is in that upper right quadrant. That is the MRN connected social and health narrative that tells that 360-degree perspective of an individual. And I'm going to put Steve and Mark and Linda on the spot for a moment and say, from a percentage standpoint of either the organizations, agencies, individuals we work with, what percent of folks actually have that true access to that full integration of clinical and social data? Steve, what's your percent?
I would love to meet them, to learn from them. I would say for me, it's always one more, because as you actually kind of progress through this, you find things and identify questions that you want to try to answer, you want to try to measure. So there's always this desire, is like, okay, we're here now, where we're going to go next. But I would say, to answer your specific question, Leslie, it's a very small percentage, if any.
Yep. Mark, how about you?
I totally agree. And, I hear Steve talking about this idea of incremental progress, and that resonates a lot with me, because that's been my experience as well. It's, you achieve one thing and then you start tackling the next problem. So I have not come across any organization that has it all solved in every facet.
Great. Linda, how about you?
Absolutely agree. I would say the number is almost 0. And I actually would take it one level further and say those of us that, air quotes, are a little bit more integrated or farther along on the spectrum, we've looked at the data and it's still almost 0. So even though we have the capacity to do the screening and the referral and keep it all integrated, the reality of doing that work is so complex that we're still really at the starting line.
Yep. So, but what we're going to hear in the popular press and what we'll read in trade rags, and we know that the things that get a lot of the buzzwords in healthcare, there might be this perspective that more organizations, more communities are in that upper right. And our feet on the ground experience is, again, we're much more maybe not all the way to the lower left quadrant, but it's certainly incremental progress. So this idea that you can begin on the lower left, we all have that aspiration to get to the upper right, but there are very appropriate, valid, credible, usable data and insights that live across that entire spectrum while we all collectively work to get to that upper right.
And Leslie, you might be able to have for a subset of the population that you can do that upper right. And that's useful. So I think the other lesson is like, don't try to stop short because you can't do it on everybody. Yep. It's, you might have pockets of the population that you're helping, you're intervening, or neighborhoods that you can actually do some of that. And that's super useful to be able to even do that analysis, or the furthest up on the chain that you can on a subset of the population, because you can learn from that quite a bit as well.
Yep. Great. All right, so very good. So we're getting good with the Menti. My question for you, I want to get a sense of your comfort level with data. 3 different choices: novice, cautiously confident, and loud and proud. So take a minute and give us your gut reaction for where you're at. Again, we have a very nice bell curve here. This is terrific. All right, so my ask of this group is, as we come together as a community on this topic of measurement, for those who are in the novice group, use us as the people we're asking your questions to. You now have a new network of friends on this topic. We have this common goal for we want to move the needle together. You now have a whole group of people who can be with you as you continue to grow your skills and capabilities. For those who are cautiously confident, share your early successes. Those are incredibly important for all of us to know. And for you, those of you who are loud and proud, as Jackie mentioned, how we want to build this library of best practices, you probably have some that we can all learn from. So please don't be shy. And my ask to you after this would be proactively reconnect with Jackie and see how we can get some of those examples for what you've been doing that makes you loud and proud as part of this repository, so we can all continue to learn from each other. A couple other quick things. This is probably going to be the killjoy slide of the entire presentation, so I apologize. But we would be remiss when I said, when we were talking about that idea of kind of that power structure with who has data. And if you need to start collaborating with people who have data, if you don't, it's invariably going to involve legal. It's going to require data use agreements, business associate agreements. It's going to ask questions about your level of HIPAA compliance, whether you may or may not be a covered entity, whether you can or cannot host PHI. And it gets really complicated, right? Because this is protected information. This is very important insights about people that we're sharing, and we can never lose sight of that. Dallas County was the target of a ransomware attack about a month and a half ago, and it crippled the community. It crippled our 911 EMS services. And so the recognition that while to show impact, we want to have access to data, and our desire to share data to be able to do that, because data is going to come from a variety of different sources, we also need to be mindful of those legal data security governance requirements that come in place. So if you don't have a best friend yet who's a lawyer, or a best friend yet in InfoSec or data governance, that would be the buddy that I would recommend finding on the heels of this, because that will invariably need to be a conversation that has to happen to do all of this work in the way that protects patients and people, while also getting us all of the insights that we need. A couple
And
other.
Leslie, I was just going to add to that, to the group. Don't underestimate how long that process takes to get in place. And I was also going to shout out that if anybody is interested in that, reach out to us, right? Like Leslie and the PCCI team, my team in Houston, we've all been through this in the development of our models, and happy to connect and share.
Yep. Very, very, very good point. So this idea of iteration, again, there's a couple of key themes that you've seen now from Steve's comments to my comments. You'll hear them in Mark's comments. You've heard Linda and Mark and Steve comment on them in our discussion. Is this idea of, things will change over time. Here's an example of what some of those data needs would look like as initiatives change over time. Building baseline insights is incredibly important. How are you going to show change if you don't know what your starting point is? So in the beginning, getting some of that foundational information is incredibly important. Early indicators of success might be some static reports. Those might ultimately change to some type of more real-time dashboards over time. And then initial results. Linda mentioned this idea of scalability and spread and sustainability. All of that, you might likely be funded to do some non-medical driver of work under some grant funding to begin with, or some internal pilot funds. But for that to grow over time, how you communicate those results, again, that data set will change as that initiative matures. Last couple things. One, I'm going to ask Steve to comment on one of our experiences around this idea of a control group. But before I do that, the final thing that's important to note on this idea of data strategy and what it looks like is we need really good study design. Because even if you measure, you've gone through the process, you picked the right things, you figured out how to get them, you start measuring and you realize you didn't think about good study design, you're going to be at the end, you're like, I'm not sure what we were actually able to show by this. And there's three things that really matter. One, it's who you're selecting for that initial cohort itself. Secondly, is the sample size big enough to be able to sell something with a little bit of gusto and oomph and statistical power? And then the third is, can we compare it to something to actually show what that impact is? Now, that's become tricky for all of us over the past couple of years because the pandemic has put a nasty wrench in how you think about building comparison groups to be able to do that. We at PCCI, through our Accountable Health Community, or AHC initiative, had a chance to be able to do that using some Parkland data for our cohort. And Steve, in just a couple minutes, share what we were able to do to help build that control group and compensate for some of the challenges of the pandemic.
Yeah, Leslie, this is a great example. We're able to do that upper right that we talked about, but do it with the subset of the population that were being evaluated, because that's where you had the data. And it was still useful because we're able to do it for 1,000 different individual patients. And the other thing that I would say is that you can't always have the opportunity to create randomized controlled trials and do that, because it's real work. You kind of start the work and you're helping the community. So how do you then account for and try to understand the true impact of the initiatives that you're taking to help with those non-medical drivers of needs versus a similar population that you have not had the opportunity to impact? And the other component, you have COVID in here, is some of these we talked about the time that it takes to achieve meaningful impacts and to change some of these drivers. It takes years. Well, what happens if you have a pandemic, or do you always have compounding factors that changes the behavior overall of how individuals, the community, use healthcare? or how their needs change over time. So one way that we work through this, again, with a subset of population, about 1,000 different individuals, is to use data science to create digital avatars in the community. So we had the individuals that were part of the program, that were being screened, navigated, followed up for social and non-medical drivers of health. And then if we found for each individual a similar person in the community that matched them from a demographics perspective, with age, gender, race, ethnicity, from a location, from their complexity of their social economic needs, as well the complexity of their clinical situation. So now for each individual, you had a similar person in the community that looked like them, and you're able to track both of them concurrently through data. And then, you know, you do that 1,000 times, and now you have two cohorts, one that you're intervening on, and then the other ones that you have not had the opportunity to do it, but they're very much matched. And then you can more readily compare the impact that these programs are having, accounting for those factors like COVID that were impacting concurrently the behaviors, the utilization at the same time. So accounting for some of the temporal factors that occurred during the measurement period. So that's sort of, I think, an example on how something can be done, and how information and data can be very useful when you have the information and the data that's required.
Yep. Steve, thank you for that. Before I turn it over to Mark to talk through some of the challenges, we've certainly touched on challenges as we go, or as we've gone through our time thus far. But this is a real example. This was an organization that Steve and I and our colleagues had a chance to work with. And by the time we got involved with them, the train had left the proverbial station. But this was their situation around, they were very much focused on food insecurity and depression as it related to senior citizens in their community. And what they ended up doing was they had the idea that, well, gosh, maybe if we serve communal food, maybe if we serve nutritious food together, we not only take care of the food insecurity challenge, but also we're able to do something around their depression. So I'm not going to read the slide. You'll get these as the follow-up. But basically, they used a screening tool, a very well-known one, Q9, and they brought people together for food. And then their results were the health clinic was able to provide 350 meals over a 6-month period. And based on total survey respondents, 15% were considered mildly depressed, and or moderately depressed, and 35% were considered mildly depressed. And our question to them was, that is fantastic. You fed people and they seem better, but how can we tell an impact narrative with this information, right? And as you look at this, wearing your measurement hat, there's a couple key things missing, right? What's the baseline? Do we know that 15 and 35%, did they start out, at 0 or 100? So like we have no way to gauge what those numbers mean, right? That would be one thing. If we were to help them create a measurement strategy from scratch, that would be a really important thing to start with. Secondly, it's a little bit unclear the connection between food and depression, and bringing those together. Is there an actual causal link between them, and how do you tell the story to be able to strengthen what that looks like? Third, it was unclear because of how they collected the data, because they didn't ask for any identifying information. Were these 350 meals to 350 different seniors? Were these the same seniors who were super hungry and kind of came back every time? So we don't know the frequency of engagement to understand what that means. And then importantly, like, we love qualitative insights also. That's incredibly powerful information. We don't have any way to qualitatively gauge how seniors felt about this particular program. So right in intention, right in terms of trying to collect data, off on having a measurement strategy in place before embarking upon this, to make sure once data was actually collected, they were able to tell that appropriate impact narrative to those stakeholders who could then be their partners in potentially carrying it forward. Okay, with that, wait, Linda, I'm going to ask before we turn it over to Mark. You're our chat master. Anything in the chat before we go to Mark?
I don't see anything new in the chat, so I think we're good.
Actually, Leslie, there is a question from Emil Owens about the domains of learning associated with measurement.
So let's hold that question, Emil. When we start talking about systems thinking, there's some specific domains of knowledge and learning that are part of that. So hold that question for about 10, 12 minutes or so, and we will get to it when we get to section 4. All right.
Sounds good. Sounds good.
Okay. So we're going to talk a little bit about challenges, and I want to recognize that we're talking about challenges because we want to keep it real here, and this is the reality of the work, and there are challenges, and we want to name those, because if we don't name them, then we don't know what solutions might look like or how we think about that. The first one here, I think, is a great segue from the example, the case study, Leslie, that you were just sharing, and that is that there's a nonlinear path to impact many times. And so, there's the number of links between an intervention and the impact we want or expect to achieve, and how we determine association or causation. And so on the left side of the screen, you can see that we have many different factors that affect health outcomes. So for example, inaccessible transportation insecurity to and from work might mean that an individual doesn't sleep enough, which is critical to their health. This can lead to their increased risk of stroke, and then in turn, an increased need for primary care or increased risk for emergency room or hospital utilization. And if we're implementing a transportation intervention, it can really be important to think about those outcome measures like quality of sleep that might take less time to measure. So in the example that Leslie was sharing, PHQ-9, right? Maybe it takes less time to measure, while we're also thinking about those impact measures around, transportation interventions that might affect ED and hospital utilization that can take more time to evaluate. So this nonlinear path is definitely a challenge that I'm sure many of us have experienced. Next slide. The second challenge is a lack of standardization. And I think it's fair to say that in large part in social care interventions, there's a lack of standardization around the types of social care services that are delivered, the credentials or staffing that might be required to provide those services, and then the duration and the intensity of those services. And if just to make this come to life with an example, if we think about food insecurity, there's many different services that community-based organizations might provide to address some form of food insecurity. We can think about food pickups at a food bank on an as-needed basis for an individual, which might be more intermittent. Then there's maybe more regular food pickups. Then there might be food delivery services like Meals on Wheels, which provide home delivered meals and food or groceries. And then and even there, I just mentioned like the difference between meals and groceries, right? So that's a variation. And then we might think about medically tailored meals that have specific nutritional requirements around them to be considered a medically tailored meal, right? And so when we think about just this one example of food insecurity and the types of services, we see variation in the types of services, variation in the individuals that might be providing them, variation across organizations that might be providing a similar service, and then of course also the duration and intensity. And this can be important because it can make it challenging when we start thinking about reimbursement for community-based services if we don't have standardization in those services that are delivered, like is more commonplace in healthcare. And the next slide here, we really have the third challenge, which is data is difficult to collect if there isn't good quality. And so if the quality of the data isn't consistent, then it makes it hard to measure and evaluate. I should not be awarded any prize for making that statement because that's obvious to all of us, right? And so what types of factors get in the way of consistent quality data. I'm going to ask you to give me a thumbs up with your emojis if you've experienced any of these. So fragmented, inconsistent collection. This makes me think about data collection practices. They might improve as we get experience with implementing a service or an intervention. It's possible that the data we collected early on isn't as reliable as the data later on because our practices change. Mix of structured and unstructured data from different sources with different lag times. One example here that I think about is because I saw a comment earlier about the importance of managed care organizations because they have access to claims data, which is true. And there's also a lag time in most cases around accessing that claims data that can be in terms of months, right? 4, 5, 6 months. And so that lag time can impact our ability to measure and evaluate. How about multiple legacy and or startup technology platforms? I think this one applies equally to healthcare and community-based organizations. On the healthcare side, we know there's EHRs that oftentimes in a health system might be different instances of EHRs, right? So just because you're on Cerner doesn't mean you're on the same instance. And then, on the CBO side, the CBOs oftentimes are documenting data in different platforms for different reporting requirements, right? And then the last couple here that we see lack of standards around what those data collection practices might look like, poor data quality, which I think really is probably, oftentimes a result of many of these factors, and then legal challenges with data sharing, right? Data use agreements, business associated agreements are often needed to just be able to share data across sectors or organizations. And even when these are in place, it can take time for that data to be reliable and consistent. So, I think I'm naming the obvious here that we've all experienced, but this is a challenge. The next one is a challenge is having the right people around the table. Now, this one I personally relate to because I do not consider myself an expert in evaluation or measurement. This is something that I learned and then along the way. Most of my experience is in the nonprofit sector, but I've seen what this looks like from, working in nonprofit, both, and then in a vendor perspective, and then now from a health system perspective. And one thing that I have learned, which I think is true, and that's stated here, is that having diverse thought around the table is really important for evaluation. And I'm an example of that. I was always at those evaluation tables because if I think about my experience in nonprofit, I was responsible for implementing or overseeing direct service programs. I had to think about evaluation. I didn't think I considered myself to have those skills. So I'd often be collaborating with folks in my organization who were technically trained. And as I collaborated more and more, I started to learn more and more and get more experience, right? And so having that diverse thought around the table is really critical. It doesn't mean those individuals should be at the table just because of their title, right? As an example, someone with lived experience can inform evaluation in ways that a technically trained evaluator would not be able to. And both of those perspectives are really valuable to an evaluation. And so this challenge, really just calls out that just depending on titles and roles might not always be the safest bet, because we need to think about skills and mindset for how we want to sort of make the evaluation come to life.
And Mark, the one thing that I'll add to this one, particularly as we will make the transition to systems thinking in a moment, is this idea that depending on how individuals around this table have matured in their careers, there's often very much of an operations mindset into how things get done, and which is needed, right? I think, Mark, think about your role, from leading programs, implementing programs. And then when we think about some of the, I don't want to say the aspiration with measurement, but there's a little bit more risk taking on how we might be able to collect X or how we might partner with organization Y. And it's a slightly different part of the brain that needs to kick in, for that type of work to be able to take some of this to the next level. And so that's one of the things that we've seen be sometimes really challenging. Again, it's this right mix of people because of how they've matured in their career, their influence, their stature in community. But for some of the things we need to do as we think about a systems-oriented mindset, they're almost too far along in career to have the brain work in that slightly different way.
Totally agree.
I was
Go ahead.
just going to add one more thing to that from a systems thinking perspective. So when we're talking about the non-medical drivers of health, we are crossing from healthcare systems to community-based organizations and eventually upstream to public health, right? So you're talking about a wide range of different kinds of organizations and people who have different kinds of training and backgrounds. And within our system, these are fragmented and siloed, right? These are sitting in different spaces. They have their own expertise and their own knowledge. And one of the things we found in our AHC work with organizations around the country was a missing critical skill is what we call boundary setting. And that's the ability to get outside of my organization and to connect with that CBO or that public health agency and to bring all those voices to the table when we're talking about measurement. So I think that's really important to think about.
Love it. Thank you, Linda. Oh, and
Sorry, I
you're
was on mute. And it makes me think about early on in my career in a small CBO doing work around asthma and smoking cessation interventions. I had reporting requirements to our grant funders, right? And this is one of the constraints that CBOs have is like, my first responsibility is to make sure we're good stewards of those funds we're getting, which if I'm thinking about this, in retrospect, and that's a limitation to thinking from more of our systems perspective and thinking outside of my sort of day-to-day, like you're saying, I think both of you are saying. And that sort of segues into this last challenge, which is we often live in silos, right? But we need to measure impact as systems. Linda, you were just naming that, what I totally agree with. Our goal should be to impact indicators at the community level, right? Community health level indicators. To measure that, it requires getting out of our silos and our approaches to measurement and really leveraging those different perspectives, like you were saying, and the assets that come along with different organizations. And I think when we do that, it's really valuable, but I'll be real, it's slow moving, right? We've all experienced this. And so that's where I think about the value of different and cross-sector collaborations and initiatives like collective impact models, accountable communities of health, other initiatives like this that are creating those spaces so that stakeholders don't have to restart the conversation every time, right? It's almost like the infrastructure is there, and now we're just evolving the conversation because we trust each other and how we go about the work. And so, we have to think about how we overcome this as a challenge for sure.
That's great. So our last mentee, you've all proven to be quite adept at this technology. The last one for the day, based on your experiences, Mark shared some of his lived experience, Linda, myself, we did as well. Based on your experience, rank order these challenges from your point of view, from most to least challenging. This one was harder. You have to actually rank order as opposed to a singular. Are people rank ordering? Huh. Ah, there we go. It just took it a minute. All right. Give it one more minute. We got a little wrangling for positions 2 to 5 are changing in real time. 1 seems to be pretty solid. All right. Very good. This also gives us some insight for the content and the type of work we can do as part of the consortium and the ongoing work we'll do both from a webcast and an engagement standpoint as well.
Leslie, before you go on, we have a question from Samantha Jones asking if you can talk more about the challenges with long-term operations mindset. What's an example of this?
Yep, that too, we're going right into that with systems thinking. So again, we just bear with me for a minute. And if we don't adequately answer that question next, we'll make sure we have a little bit of time left for Q&A before we go into the breakouts. We can revisit it there. Okay. So this idea of applying measurement thinking through a system lens, that's the last piece that we're going to touch on before we go into our breakouts. And so when we think about this idea of what makes a systems thinker, whether from a learned practice, a skill set, Linda, you mentioned boundary spanning. That's one of those key skills, that idea of an accomplished associator, being able to make some of those connections. There's a slide that we hid because we knew we had a plenty to cover that specifically talks about those attributes of what makes a system thinker. But these are some of those kind of the essence, and you can see maybe how that's a little bit different from an operator. And so this idea that this being able to look at those interconnected things, if you're someone who's very KPI driven and you like, my job is to storm the hill and I have such laser focus on accomplishing that goal, I might not have that gift of being able to look a little bit to the left, a little bit to the right. I'm like, hell's bells, I'm just accomplishing the goal. And that's really important to have that. Right? We need people who have that. Systems thinkers still can have that, but they have that ability to look a little bit more broadly. They're a little bit more comfortable with ambiguity. There's a little bit more gray within systems thinking. Again, a strategy or an innovation-oriented individual might be a little bit more comfortable with ambiguity. An operations-oriented individual loves the clarity around black and white. That's one of those distinctions. This idea of looking at the intersectionality of relationships. There's a huge people element to what requires to be a systems thinker, and those relationships of projects, those relationships of people, those relationships of goals. Again, we've touched on this a lot, being able to look at the whole versus the individual parts. So, a summary of those, both things on this slide, about that boundary spanning, comfort with ambiguity, loving uncertainty, all of those types of things really reflect a little bit of that different persona in a systems thinker, in a learned or just innate skill set versus someone who has a little bit more of an operational mindset. Linda, anything else you would add?
I think that's a great description of systems thinking. I guess just to give it a little bit of a visual perspective, when I think about comparing and contrasting systems thinking to the more traditional linear approach, I think about spaghetti. So your traditional kind of linear thinker loves that single strand of spaghetti. They're going to go from one end to the other end in a very straight fashion. A systems thinker loves the bowl of spaghetti. And when you throw all those noodles in together, the way they all mix, the way they all connect, the way things maybe come together unexpectedly with some of that uncertainty, that's really what a systems thinker is. And so when we think about innovating from a systems perspective, it's often not like this great brand new innovation. It's pulling pieces together that maybe other people haven't thought about how they could integrate or fit. So I think that's a great way of thinking about systems thinking.
Thank you, Linda. Okay. So an example here, I always like this big I impact, little I impact, big S system, little S system. So just a couple examples. Here, if we're beginning to think about kind of systems thinking around maybe little S systems, and this example is around an ED department with asthma-related disparities and how we might be able to look at visits within a particular county. we're thinking about some of those connections here. You have some clinical programs, you have the ways we're thinking about those clinical community linkages, you have multiple different community programs as a whole. If we were to begin to transition that to big S systems thinking, we would also think about how do we bring the local housing authority into the fold? What are some other interventions, legal or otherwise, we can do with property holders and landlords? What might we do about this recycling plant that has such an impact on asthma overall? And so that big S system adds more of the pieces of pasta to that spaghetti to make it more intersectional for how all the different dimensions of this challenge really come together to be able to overcome it over time. There's a group called the Build Health Challenge. They're one of my favorite exemplars. It's a nationwide program that uses systems thinking into their approach for community-based initiatives that we would say fall into that camp of non-medical drivers of health. This isn't their exact schematic. We took a little bit of liberty with it for purposes of our group. But if we're going to take this idea of systems thinking and really link it with impact measurement, and we're here to say, what are those 5 areas that really matter? It's around this idea of partnerships that have bold goals. We haven't talked about accountability and shared accountability. That's huge. And so how do you get that shared accountability as we're putting together this mix of programs, particularly when we're going to have multiple programs operating at the same time to tackle one key problem? So the other key around this systems idea is having a portfolio of interventions. As Mark mentioned, you're not going to solve food insecurity with one thing, right? You're going to solve food insecurity with a mosaic of different programs. So how do you build what that portfolio looks like? How do we think about making sure we capture community voice at all times? And then again, how do we make sure we're data driven? So I'm going to make this real in my final 2 slides in 2 ways. One, you might be surprised that we've been with you this amount of time and we haven't shown you something like a logic model. For those of you who do measurement and you've been measurement aficionados for a long time, it's kind of that gold standard for how you get all of it on a single page. For me, it's the way you think about that. How do you start with the end in mind? If you're not familiar with logic models, they might sound a little academic and a little wonky, but they're actually very practical in terms of how they have that forcing function to get everything down on a single sheet of paper. And so this is that idea. You have your situation, you have the goal that you're trying to accomplish. You begin to think about who needs to be around that table and how you're going to make sure community voice is part of that. You're going to create your portfolio of interventions. Again, it's not one thing, and you might not be able to do all of them at once, but you get on a single sheet of paper those more immediate interventions, what those output measures might be, those partially upstream intervention, what those output might be, and those things that are a little bit further upstream. In that example I gave, that would be moving the recycling plant, etc. And then you think about those initial outcomes, those intermediate outcomes, and those longer term outcomes. You get all of it on a sheet of paper, and then you say, okay, that's great. Here are the 2 things we can start with. But you thought about those 2 things in the context of the whole, in the context of the broader system. So this type, there's 101 different versions of this type of tool out there. For those of you who were kind of the loud and proud, I'm guessing you've used a tool or a framework like this in some fashion. For those of you and your uses of data who are a little bit more novice, either engage one of us after this call or use your good friend, as my father says, the Google, to go out and take a look and maybe find a version of this that works for you. But the example,
Leslie,
yeah.
I just wanted to add, I count myself as somebody who used to be scared of logic models, and they force the conversation, right? They facilitate a conversation around these key questions, and that's what I love about them, right? And so I wanted to raise that up. It's just these are the topics that we need to talk about, and it provides some structure for doing that.
Agreed. So this is from the Build Challenge. Again, it's from their website. They have probably 20 or 30 different examples of how they've taken those inputs, the different types of folks who need to be around the table, those output measures or process measures that Steve started with, what that could look like across these 1,000 flowers blooming for the initiatives, in this case, where the theme or the bold goal was around sustainable housing, and how they were thinking about initial outcomes, intermediate outcomes, and then those ultimate outcomes as well. So with that, as we're just about to transition into our breakout groups, I want to hold us accountable as a presentation group around those principles that we started with. One, I'm hoping that we gave you a sense of who's around our collective table by learning where we stand in our comfort with this topic, whether we're novices or loud and proud individuals, which some of those challenges are most top of mind for us as a group. As we put together our collaboration plan for this as part of the consortium, we're going to use some of those inputs and we'll actively reach out to you. And we hope you feel comfortable enough actively reaching back out to us as well. We hope we've made the case that measurement is the first thing, not the last thing that you do, for all the reasons that we've described, both through our experiences, our lived experiences, as well as some of the samples we showed during our slides. We probably shared a couple things that were overwhelming, but we hope that we also provided a couple of those nuggets or those tethers, places you could start to grab on and get going. And perhaps because of our passion for this topic and some of the questions, maybe we do really believe this idea that measurement is for everyone. It's certainly something that we believe from the top of our head to the bottom of our toes. And maybe if you were a little skeptic coming into this, hopefully we've convinced you that that's true. So with that, Jackie, Jessica, and Co, let me turn it over to all of you for what's next.
Wonderful. Thanks, Leslie. That was a great presentation. Certainly provoked a lot of thoughts and questions in my mind. So now we're going to ask everybody to stick around. We're going to put you into breakout rooms, and we're going to ask, we have some facilitators in the room who are going to guide us through a few questions. We're interested in getting your feedback on this presentation. What else, what excited you, what worries you, and any other questions that we should pay attention to as the consortium moves forward. So Angie, take us away. We'll break up into our breakout rooms now.
Mark and Steve, if you two would like to go into breakout rooms, I can send you over there. Or if you'd like to stay here in the main room, stay here at the main room.
I think we decided I'm gonna stay just in case people come in early and just chit chat if we need to. But Mark, if there's a room that you love to be part of, just
Yeah, can I have like 1 minute just to run to the bathroom real quick, and then I'll be back.
Of course.
And you can put me in. Okay, thank you.
Perfect. So I think, Jackie, just so you know, we have about 6 to 8 people in each room.
Hey Angie,
Welcome back.
we only had one person that was not part of our team in the room. So
All right.
can you pop us
cool.
into another one?
Yeah, let me reassign you guys. Give me just 1 second. So I'll start inviting you into random places. Oh, give me 1 second. Yes, Jessica. Send them to group 1. Y'all are going to group 1.
Okay.
Okay. You were in. So,
We were in 4.
And I'm actually gonna jump to one of these rooms if that's okay.
That's great. Are you able to do that on your end? Do I need to send you?
I can do it.
Perfect.
Related tools and calculations, but they're not necessarily exact. Different tools, it's like, is very clear that per day, regardless of their focus. Yeah, it's numbers.
Let me ask this question. How much is new to you guys? Do you know how much veterans in the room? So if you were confident about their data to make we have a bunch of veterans.
Okay, Mark, I'm sending you to room number 3.
Sounds good. Thank you.
Hi, Jackie. Welcome back. How was the room?
It was great. I'm thinking about jumping into the other one.
Okay, great.
The only thing I'll say is the feedback is so helpful for how we think about the role that this particular affinity group within the consortium can play. So we'll take this feedback and any other feedback everyone's willing to share with us and use that as the foundation for what comes next. So we so appreciate you weighing in and sticking with us over these 2 hours. Just a huge amount of gratitude.
Great.
No, the only other thing that I would add, and again, a sincere thank you for the active participation, is, and I put it in the chat, and one of the comment was around the translation or sort of really understanding how this plays out across rural communities as well. And as part of that, we are certainly looking for an executive to join the steering committee that has the expertise, the passion for the rural health. So if you have any recommendations, we're very much welcome. Please reach out to us.
Beautiful. Thank you. We'll turn it over to you, Jackie, to close this out.
Thank Thanks, Jessica. And thank you all for a robust conversation on evaluation today. Echoing Leslie and Steve, we are really grateful for your input and are interested in your suggestions and feedback. And we do want to stay in touch with you in other ways going forward. Connect with us through our newly launched website for the Texas Consortium. That's at thedriversofhealthtexas.org. I'll drop it in the chat right now. Alternatively, you can always connect with me directly at my email. It's jk90@rice.edu. And any questions you have, I'll be able to find the right person to connect you with. So don't hesitate to reach out. Finally, look out for our email after this. We're going to send along a survey link and hope that you can spend 2 minutes sharing your experience about the webinar. And yeah, again, we really appreciate your feedback. We've appreciated your time and look forward to working with you in building a robust field of practice around the integration of NMDOH into health systems across the state. Have a wonderful day and thanks for coming out today.